You're listening to a speech therapy PD podcast. Earn 0.1 ASHA CEUs for this episode by completing the accompanying course online at speechtherapypd.com.
Okay, folks, welcome back. Today's guest is a repeater because I just simply adore her. And y'all, we literally spent the last 30 minutes just catching up, even before we went to record, swapping terrible fish parenting stories because that's what happens in our households. But hi. Okay, so to catch people up to speed, you came on a couple of weeks ago and talked about trauma-informed feeding, and you wear a lot of hats. And one that is very near and dear to my heart is that you shared your own personal lived experiences as a mama and caregiver. And I love that we have a safe space to talk about what we've been through and how that influences and impacts our evidence-based triangle. So thank you for speaking from the heart.
Thank you. And like I told you before we started recording, as I feel like any neurodivergent person and anxious person, I had a full worry fest after that. I just overshared and that I trauma dumped on everyone. And thank you for making me feel better that what I shared, I think, is going to resonate with a lot of people who are listening, because it definitely is. It's scary to share your personal experiences, but I think not only for other people in our field, but then the families that we work with, I think we were taught not to always share our personal side and show that we're human. But every time that I do, I feel like I connect more with my families and learn more about them, and they learn more about me. And I think it actually really helps to take steps forward together.
Yeah, you're building trust.
Mm-hmm.
And that's a huge component. I mean, the crux of what we do as feeding therapists is we can't do thorough intervention, unless we have a rock solid evaluation. Amy Delaney always talks about, Dr. Amy Delaney out of Marquette University, she always talks about how treatment is sexy, right? But it's the eval. Isn't that funny to think of like anything that we do is sexy? And I'm like, I definitely had chicken shit on me this week. I went to a tiny human's house and they have chicken farms, right? Like real big chicken farms. And the puppy jumped in the poo and then jumped on me. That's not sexy. But you know what? We had a really good session and I just was odiferous. Move it on.
Yeah. How real is that as well, too? Yeah. And I do think I like actually what Amy says about people find treatment to be sexy is and we'll get into this further along in our conversation, but people, especially in the feeding world, take a course, they learn a certain set of skills, and they want to dive in with all those skills, which is so wonderful. But sometimes it's really important to zoom out and figure out where what you learned in that course or what those new set of skills are, where it fits in the timeline, because it may not be right now. It may be that you have to do some things first and then they'll be ready for it and it's going to be great then. But if we jump too far ahead, we haven't quite prepared them and laid a really rock solid foundation for progress in feeding therapy.
Yes. And if you take it back all the way to the beginning, you have to establish trust with the caregiver in those first few interactions so that when you're doing that eval, you get honest, open-hearted answers. Yes. And that's hard. It's hard. And we can acknowledge that it's hard. And
that honestly may be the hardest. And also, I think that's why people want to skip some steps and go to the tangible tools that they've learned in a course, is because that's something that is concrete. It is something that is not emotional. It is not something that you have to ask deep questions about or unpack things. The beginning is the hardest part, and it is that way for a reason. And we need to be willing to lean into that hard part before we move forward.
Yes. Which honestly, I think that's where our little neurodivergent brains thrive, because like I can have an awkward conversation with a total stranger very quickly because I'm pulling patterns that I'm seeing together, and that's helpful for me. But I also understand that I have introverted colleagues that can be more of a challenge with. And that gets us back to, wow, we started at the end and then moved backwards. But that also gets us back
I love to backwards chain, though. That's one of my favorite things to do. So
but like if we go all the way back to where we left off last time, we went through, and I have my handy dandy notes. We went through and talked about like the principles of trauma, and then the difference between trauma informed versus trauma sensitive.
Yeah.
And those are great starting points. So if you're listening to this and you're uncomfortable starting those conversations, you can take these principles and start soft and slow. And that's beautiful, because you're honoring this sacred space of eating, of mealtime interactions, excuse me. Yes.
And kind of a quick synopsis for anyone who's listening and may not have listened to the first recording and first episode that I was on, which go back to it. But if you are going to stick with this one, really the place to start is defining trauma-informed care and what trauma is. And what we talked about a lot is it's a really big buzzword, especially when you get on social media. And so sometimes people use that term and name themselves as a trauma-informed therapist, but don't even really know what that means. So the definition of trauma is it's a lasting emotional, psychological, and or physical response to a distressing event or series of events that overwhelms a person's ability to cope, impacting their sense of safety and well-being. I think there's so many parts of that we can think of. So many of the clients we've worked with where you see that they struggle to cope. You can tell their sense of safety is impacted, and it is impacting their well-being. We talked about the types of trauma. So the kind of main types is actually, there's more than even what we talked about last time. So we talked about acute and chronic and complex, and then we got into developmental trauma. But some that we didn't mention that are just as important to think about are medical, historical, racial, sexual, and then vicarious trauma. And
what is that?
So vicarious is when someone else has a trauma and then hearing about it, seeing it, or experiencing it through that other person ends up causing you trauma as well too. Yeah. And I don't know if this is I'm going to go back to sharing my personal life, is my husband is a Purple Heart veteran. He was injured in combat in his first tour in Iraq. I did not know him then. I knew of him through some of my friends and family members that he then served with. But I always say, I feel like in the glimpses of my brain, I heard about when he got hurt, but I didn't know him. And so then when we met years later, he was already out of active duty. But when he would talk about his injury in combat, I felt like I was having that physical, psychological, and emotional response. Like I felt a sense of anxiety. My heart started beating faster. My chest got tight. I worried about him, even though this event had already happened. And so I don't know if that is a perfect example. Like if I was sitting in front of a psychologist, would they say that's an exact example? I'm not exactly sure, but like, I think that's a glimpse into it. Is he shared that, and I care about him so much that I actually ended up having my own physical response to it. And I think that probably would then fall under acute. It was short-lived. I know he's not in immediate danger. It's not recurring for me, but I felt it in my body. And that's also what we talked about too, is when you hear about someone's trauma or they share it with you, it's not for you to judge if it is trauma or isn't. It's their perception of it and how it impacted them. And we don't respond equally to events. And so just because maybe it doesn't seem like something that would cause trauma for you doesn't mean that it's not going to cause trauma for someone else. And you have to wholeheartedly respect that. And especially if they're sharing it with you, you also need to respect that they are feeling vulnerable with you and safe enough to trust you with that information as well.
I had a little girl years ago, and I knew it was trauma, but I didn't have a term for it. So you've taught me the term. She heard about her cousin choking on a grape. And then and the other child was fine. So no stress there. But just simply hearing about the event, she stopped eating grapes. Then she stopped eating all spherical shaped objects. And then there was other trauma going on in the home, like caregivers separating and divorcing and these components. But that was like essentially her tipping point was hearing her cousin. And by the time she got to me, we were hardly eating anything at all. And it was kind of scary. But
and we didn't get to touch much on the medical trauma, but we know I know the kind of clients you work with, and you know about mine is a lot of them come with so much medical trauma, and it may not even be the client itself, but their family, their nucleus of caregivers, and who was there with them during those times. I mean, there's so much attached to that. So that's why we talk about you have to stay in the sticky, messy area at the beginning of meeting a family when you're evaluating them, because with that list that I just went through, I mean, it's more of who doesn't have trauma than who does. Like that list of who doesn't have trauma is going to be way smaller, probably tiny compared to who has some sort of trauma, whether it's current or past. So we also talked about the 6 core principles of trauma-informed care, which those are safety, trustworthiness and transparency, peer support, collaboration, and mutuality, empowerment, voice and a choice, cultural, historical, and gender considerations. And like those are that could be probably a podcast all in itself. But we really have to just embrace that safety is what drives this, connection is what drives this, and it's the foundation that everything after rests on. And that's where we started to talk about too, the difference between the terms of trauma-informed care versus trauma-sensitive care. And since the last recording, I was thinking about where some other people might know these terms for. And so I think when like in a lot of places, there's this learning of like culturally informed, right? So being able to learn about different people's backgrounds and experiences. And I think in that space that has shifted a lot to trauma. I mean, not trauma sensitive, but culturally sensitive, because you can't learn everything about every person's culture. It shifts with every experience, every place, every person. So, and it also is a difference between just learning facts and understanding and embracing that is a constant process of learning and work. So same thing in the trauma space. Trauma-informed care is the one that most people use and are familiar with, but I really like to use trauma-sensitive because for those same reasons, trauma-informed is like, okay, I took a course about trauma, or I read this blog about trauma, and I can tell you what trauma-informed care is and list some data points about it or facts about it. Whereas trauma-sensitive care is when you make the decision that you are going to embrace all of those principles and all of this understanding to walk the walk and talk the talk, and be able to not just be able to list objectives and data points about what it is and what it means. You have to be able to truly create a space of connection and trust. You have to be able to embrace it and exude it in your body. And people can tell the difference between that. They know whether you're just spouting facts at them or whether you are opening yourself up to the other person. And truly that's that difference. And I think it's one that's not as tangible. I think it is one though that you feel, and when you see it, you know it.
That's when I feel there's like those zing moments. I don't know how to quantify it better than the zing. And yes, for those of you that are Hotel Transylvania, I quoted Hotel Transylvania with the zing, but when you have those zing moments of you're present, right? Like you're really present with that caregiver or with the tiny human, and they're sharing these moments. Or when so within the framework of where I am, we have our like eval that we go in and we're doing our eval, and then we'll have our like individual follow-up meeting subsequently. And what I find is that sometimes in the framework of early intervention, when you have like the IFSP team, they show up to do that initial eval, and it's a lot. It can be very overwhelming because all of a sudden you have like 2 to 4 humans in your home, and it's a lot to take in when we're going through like a 5-domain assessment with like pull off parts that are specific to either PFD or, whatever the etiology is. But we can amend our evals and our reports if on subsequent appointment we get new information and new insight because you had a zing. And you can also make updated plan of cares or updated IFSP reviews if you've had a zing and all of a sudden like another layer gets, I don't know, peeled away or added.
Yeah.
But it's that zing to me is living in those principles.
Yes. And like you said too, we're taught that we have to get all the information and all the data and all the answers to all the intake questions in that evaluation
in 30 to 45 minutes.
Yeah. And it's hard because a lot of us are bound to insurance and making sure we're showing things to insurance so that things will get covered. So there is that caveat that makes that challenging. But I think it's possible to do both. I think that it's possible to, and I also would argue that when you're present, you'll actually get more information. And being present is also way easier said than done. When I started DIR floor time, I had my own private practice. So I had the luxury of being able to videotape myself, which you need to do for the course. And I think everyone would have told you, oh, like you're such a good child-led therapist and you're so present. And I watched the videos of myself and I was like, ooh, I'm not as present as I think I am. And I was, it's not like I was checked out or I was just trying to hit a bunch of boxes and checkpoints, but there was time where I could see on my face myself processing what I wanted to do and where I wanted the session to go instead of where it was going. And had I leaned into that, who knows what that would have opened up. So it was really insightful to be able to, and it was really hard to learn how to let go. There was parts of me that were worried about being too messy, being too loud, being too destructive in our play. And that there was a lot I had to unpack with that. And when I then wasn't allowing myself to do those things, the client I was working with then had some limitations because I wasn't comfortable with it. And I was to a certain extent, and that's what I could see in those videos. So I've learned over time, and we'll kind of keep talking about that when we get to like some treatment stuff, but it is way harder. That's kind of what I hope everyone hears from this is it's way easier said than done to be present. And sometimes you might think you're present, but if you can, and you're allowed to like videotape yourself or your sessions, which you're not able to in every setting, do that. And not to watch the client per se. I mean, yes, do that. Watch yourself and see where you tense up or see. Sometimes too, I have an AI scribe and I'll pull up the transcript like of dictation instead of the AI scribe note that is created just to see how much am I talking versus allowing the client to talk if they're a speaking client. And when I get nervous and I get a little dysregulated or I feel a little out of control, I start to talk a lot. I talk faster. I fill in the gaps. I'm not as comfortable. I'm starting to feel out of control. So I want to control it, and I control it with my language. So on those transcripts where it's dictated, I see that it's me talking. And what I've learned over time is the less I talk and the more pacing I provide, the more I get out of my clients. So we're kind of like jumping ahead, but it's so important to think about these things again at the beginning.
Yes. Also, logorrhea, pressive speech. That's what the technical term, but
that's me.
But I will feel that when I'm nervous and it's too quiet that I want to fill a void. And I do that during, and I catch myself doing that during evals when I fret, did I phrase this question correctly? And then I try to recast the question or like restate the question because maybe I wasn't clear enough, or, this past week there was like a Nerf gun battle going on between the tiny human, and like we're trying to do our eval and not get shot, but like, casual, normal things. And making sure that I'm present with the caregivers, dodging Nerf bullets, and creating a space for them to answer the question. I'll get nervous and just keep over talking.
Yep.
Like I'm doing right now, just recasting that or sharing that experience. But when you're using these principles, how do you go through your evals? And then I'm genuinely curious as to like, what resources did you come up with to like pull an eval? Because that's always interesting to me where like people formulate their evals from.
Yes. So when I'm doing an evaluation, and I'm going to talk more about my 18-month plus crew, because I do treat infants, but they're doing different stuff. So families will ask me, what do I bring to the evaluation? And they're ready to just dive right in. And they are expecting me to say, bring some challenge foods. And also I used to say, bring some challenge foods. Now I say, if you're going to bring anything, I want you to bring trusted foods. And to be honest, we may not even pull it out. And that sometimes takes people off guard. They're like, oh, that's weird. We're doing a feeding evaluation. But I want to gain that trust and that buy-in that I'm a fun person to be around. I'm a safe person to be around. We're going to have fun here. I also just don't think that the evaluation, this might be a hot take, but I don't think the evaluation is when we should challenge kids with feeding. I just
agree.
I don't
100%.
think, I don't think that they are prepped in their bodies to be able to then try new things. I mean, they don't even know me, right? So with that, I say, we're going to end up playing. I'll probably ask you, the caregiver, more questions than anything in the midst of the play. And then if we start to notice some hunger cues, because a lot of my kids don't know if they're hungry, but I have one kid who will put the ball pit balls in his mouth and start chewing on them, like really happy, really excited. And so I got to say, like, oh, your mouth is chewing on that. I wonder if your mouth is feeling hungry for some food. Or I'll just notice a change in regulation that tells me, oh, we might be hungry. So we'll take the food out. A lot of our kids too are not able to generalize and carry over feeding skills from one space to another space. So we'll just leave it out and see what they do. I mean, that tells me so much, right? We don't have to sit at the table and eat. I could just see, how do we respond to food? Do we ignore it? Do we come over? I think on the other recording, I talked about one of my kids who has this Benko box that will just flip the lid down and then look at me like, don't offer me that. Going back to play, why did you do that? Or they will go over and eat, and then I do get to see it, but I kind of just want to see what they'll do on their own about that. And then every once in a while I have a kid that's like, I'm hungry, and we'll say, cool, let's go have something. So really our evaluation focuses on play, because I can get so much information about how they regulate themselves, what their sensory system looks like. And I'm not an OT, I'm an SLP, so I'm not trying to do it in the same way that an OT does. I just want to know, are they under responsive to noise? Are they over responsive to noise? Are they like spinning in the room where their visual system wants lots and lots of input? Or do they like to sit and just kind of look at the lights or some of the linear patterns? Are they a kid who's going to go towards my squishy fidgets or want to do big jumping and are bound X? So I start to know a lot about how their body processes information just by watching them play. Then I start to see, how do they engage with me? Do they engage just with their caregiver? Do they come right over to me? Is it something a little more subtle through where they position their body, what they do with the distance that they're, I mean, I have kids that come and like flop right on me. And that also tells me a lot about their safety systems. I'm like, I'm a stranger. I'm glad I'm giving off this really welcoming presence, but we're coming in hot.
One of Bear's friends, whenever he sees me, no matter where we are, he always runs up and he goes, I need a Bear Mom hug. And yes, Bear Mom does deep pressure hugs. So I understand why he wants a Bear Mom hug, but like also we're a sensory seeking child. And I always fret, like, who else do you run up to and are they safe?
Yes.
Yeah.
We have to do that. I have a daughter who loves to give big, deep hugs. And we've had to teach that you do need to ask and receive permission before you do that, because not everyone likes big, deep hugs.
Yeah.
And one of those people is one of her best friends. So she had to learn that. And it was really hard to see her being like, oh, you just want to hug her.
She wants to pounce, and it's like, no.
Yeah. So she's worked on being able to not impulsively get, and she's strong. So she'll give, you're like, I can't breathe. But that tells me so much right there. How are we engaging, or are we not engaging? And that's what I talk about too. You might have learned all these amazing tools from a course, but if you're sitting with a kid who's not even engaging with you, we can't jump to that. We have to work on that first, because how are we going to engage with the food if we can't even engage with each other?
Well, and when I'm doing them, when I have the families come to the clinic, or like now I'm in home, I always tell them I need to see your baseline. I need to understand, what does this normally look like? So have them, like, if we're packing school lunches, or if we're packed like something like that, bring whatever normal utensils, your cups, your silverware. Yes. Like in clinic, you have your own, you have stuff, but show me how they're doing it and what they're doing it. And I will break bread with the tiny humans. Now, will I do that with every tiny human? No, because I don't eat meat. And then sometimes I'm not quite sure what it is that we're consuming, or how it was made. And yes, those are honest. Because
those are the kids where you see the really nice baked good, but they're doing like the snot wipes, like all the way to the
and you're like,
and you're like, ooh. Thank you so much. That's so kind of you. I'm going to take this home.
Yes, I love it when they take a bite and then they hand it to you because they're sharing. I've gotten really good with the sleight of hand. They shall love that because it's like a partially chewed cookie. But like,
so one of my kids this week, I have my water bottle here, and I bring it in all the time because I want to show that I'm also drinking from my straw cup. I like the straw version of this water bottle. Yeah. And this week I looked over, and I mean, he's a tiny human. He's not even 4, and he's holding it. It's heavy. It's 40 ounces. And he's like mid sip. And I'm like, well, okay. And so I guess we're sharing today. And so, and he's done that. And every once in a while, and I have my own private practice. I don't work in the hospital anymore because this would not be kosher according to infection control. Every once in a while, I'll risk it, and I'll take that bite if they share it with me, because I know that this is that's the zing sometimes. Sometimes you get that gut feeling that that's the zing. And I'm like, if I don't, and it's going to feel like rejection to them. And I mean, I try not to, but I can think of a couple of kids where I'm like, okay, if I get the sniffles in 3 days, I know where it came from. But if I had said no, I would have broken that connection and that engagement and would have left them being like, I'm trying to connect with you. And you said no. And so I've taken that risk a couple of times. Again, not often. And I'm secretly also cringing inside as I do it. This isn't feeding related, but I had an autistic boy who we really opposed each other in every aspect of our personalities. And my one goal for the year was like, we are going to form a connection. We're going to figure this out and we're going to bond. And by the end of the year, and even 2 years later, he asks like his teachers I'm friends with and like other people on his team. And they'll text me saying like, so-and-so was actually walking down the hall going, Miss Thompson? Hi, Miss Thompson. Oh. And so the one day that I was like, oh my gosh, we did it. He came up to me and he gave me a kiss on the cheek. Mm. And I was like, okay, I'm going to let him. Like, I mean, this kid, he didn't even entertain me at the beginning of the year. The engagement was not there. Regulation wasn't there. So for us to get here, I was like, this is the moment. And Michelle, it was the most disgusting kiss ever. It was wet. It was slimy.
Yes.
He had the biggest smile on his face. And I was like, buddy. And then I was like, oh my gosh, I have to. I hung in there with every might, like just making it look like I was enjoying myself. And inside I was like, this kiss is so gross. I love you so much. This is a gross kiss.
But okay, to take it back to the evals with the tiny humans, like the under 18 months, like when I get thrown up on because I'm burping at baby, so when I'm doing my evals, like I love to watch the caregivers like nurse or bottle feed or do that. But when it comes to the burping, I love to feel how their body's processing it. That sounds weird, but like, are you an easy burper? Are you a hard burper? Like what does your stomach feel like? What's the gurgling sounds? But when said tiny human has a blowout diaper or throws up on me, because that inevitably happens. Yes, the same cringe moment, but it is, I have to tell Bear I said cringe because I won't let him say that word in our house. He is going to die. That is hysterical. But like, it's that to me, when you're doing your eval and like, you know, we haven't explicitly said the 4 domains of pediatric feeding disorder, but you've been talking about like the psychosocial. We've been talking about like what foods are they bringing in? That implies nutrition, like what utensils, there's your feeding skill. But like that medical piece, like that's where hands, I want to feel the tiny human.
Yes. Especially those babies where the burp doesn't feel good. You have those babies where they burp and then they cry immediately after. And you're like, yeah, that didn't feel good in your body. And whether that's from the medical piece, but it's also how your body's processing that information that was just sent through, right? So
and there's your sensories.
There we go. So the other thing too, and kind of to bring it back for those people who are really bound by insurance, what I have really relied on when I'm evaluating kids with all different types of feeding and swallowing needs and differences is I use a lot of PROMs, patient-reported outcome measures. So I heavily rely on the NEO-EAT, the PD-EAT, and then to kind of pull in the psychosocial domain a little bit to understand just how stressful is feeding and eating and meal times in the family. I'll use the FAM, the family management measure of feeding, and then the feeding impact scale. And so sometimes too, you don't necessarily get something tangible to be able to prove, quote unquote, to insurance that this needs to be covered. But if you have what the family is perceiving in their home for their child, the stresses of it, that is just as viable of information and data. And you can turn that into a goal that is objective and use that. And so that also allows you to be a little more flexible in your evaluation with how you move through it, because these outcome measures can do the work for you sometimes. So I send those every single time.
So folks, if you're not familiar with the tools that she just described, all of those instruments, almost all of them are from the feeding flock.
Yep.
And we had, I think about a year, maybe a year and a half ago, I did an interview with Dr. Jean Marshall from Australia and Dr. Memory Goza she's chair of the University of Alabama. Jean was recently made, I'm sorry, I misspoke. Memory was just recently made a fellow of ASHA, I think this past November or the November before that, for her significant contributions. But they specifically talk about PROMs. So we have an episode on PROMs and why we need to use them. But Feeding Flock, their team is phenomenal. It's Kelsey Thompson, Haley Estrom. Oh my God, the pretty dirty blonde hair. I can see her face. She volunteers with Feeding Matters. She just got her.
And Britt Patos is on some of those too. And her work about nipple flow rates and venting systems and bottles, I mean, is incredible. I mean, they're like the backbone of my intake forms, because I don't have these in my system because they're a little longer, but the CHOMPS is another great one to get some more data about the parents' perceptions of what they're doing from an oral motor standpoint. We have the Geiger as well too, to look at gastrointestinal reflux and how they're doing in that domain as well too. And all of that just feeds into what then we see, or maybe we don't get to see per se, because we make plans and then babies make other plans. They stay asleep or they don't eat.
and that's in and of itself. I've had caregivers say, well, will the insurance pay for the eval if my child doesn't eat? And I'm like, yes, because this supports the psychosocial. This supports the, if we're abstaining from foods at home and we're abstaining from foods in an eval, then that is a critical data point that you can offer for why they're there.
Yeah. If a baby will not wake up on their own, or even with stimulation, like with caregiving of like changing diapers, that tells you something about their state regulation. And again, how they're processing the world on the outside. And I've had babies where the parents tried everything. And I said, listen, if they don't eat, it's fine. They're telling me they're not ready and that they need to be asleep. And one of the babies I always think of was, she was not waking up for anything. And the mom came in the week after and said, you know why? She had the biggest blowout that like ruined the car seat, the kind where you have to wash the car seat down, like hose it down. And I was like, see, that's why she was asleep. Her body told her something big's about to happen. And I'm not ready to handle it. I'm definitely not ready to eat, but I'm not even ready to be awake to process this information because it's too much. And she said, then she had the blowout and then she was starving and then she ate. So I said, see, like if we had really, really, really forced her to be awake because it was the evaluation and it's a feeding evaluation, that's what we're supposed to do. It wouldn't have even represented the baby at all. So I also wouldn't have even gotten accurate information for my evaluation because the baby was not in a state to be ready. There was no readiness for feeding. So it goes across all of those age domains for sure.
Yes.
Yeah.
This is, I got to be honest, folks, if you're listening and say you're faculty and you teach a dysphagia class, even if you only get one night, please pull in these tools because those tools are fantastic. I have my graduate students actually practice administering them on each other so that they can. You have to have, just like we opened with, you have to have that insight and understanding of trauma in order to ask these questions, in order to fully embrace that trauma sensitive practice, to ask the questions that are on those prompts because they're personal, they're in depth. And the information that you ask on these assessments perfectly segues into treatment. because some of those questions have to do with food availability and food scarcity. And let's acknowledge that while most states have secured SNAP benefits and they're not currently at risk for funding, we do have, and today, y'all know I record in advance, but today is Friday, January 16th. And at this time we have communities that are experiencing a high level of ICE activity. And what that means is that some of our caregivers can't or don't feel safe to go out in public to get groceries, to get supplies, to get resources, and are missing WIC appointments, or missing the appointments because of safety. And do they feel comfortable sharing and disclosing those fears with you? I don't know, but this is to me where trauma sensitive, knowing how to administer an eval and extrapolate the information to put into practice, but also understanding social determinants of health and community access. All of that overlaps right here. Yeah.
And that is so important for how we open ourselves up to understanding what a person has been through, or at least trying to get a glimpse into what it's like for them. And it is so easy to be in a different place in your life and have different experiences, and to be able to say, well, like, why don't they just feed them this? Or why don't they bring this food to our sessions? Why do they always come empty-handed? Or why aren't they just trying to offer XYZ? I feel like that is really easy for people to get caught in a thought loop.
I have been there. I mean, full disclosure, when I first started out, I was like, well, what do you mean you don't have food to practice with? What do you mean you don't have? Because I didn't understand food deserts. I didn't understand how many families rely on breakfast and lunch to be served at the schools. Like, it blows my mind, even now in our little community out here in Augusta County. Like, we eat breakfast together as a family, and my boys will say, no, Mom, my friends have to get there early. As soon as they get off the bus, they have to go eat and it's a reality.
And it is something that you have to be willing to listen and open up your mind and open up your heart to even ask some questions, and maybe just, again, share some things about your experiences to be able to hear that from someone else, because that is really personal and centered around pride and worries about what people are going to think about them as a parent. And a lot of people show up. This was part of the keynote speech at Feeding Matters last year with Dr. Kofi, where he talked about people will show up as their best selves, in their best dress, with their best food, because they want you, because they care about their kids and they're there and they love their kids. And so they want to show you that they're doing the best for their kids. And really, there's a lot of struggles behind the scenes, but not everyone's ready to show you what's back there. And so we have to want to look deeper and want to understand more that I had families where all they could afford, they were like between their SNAP benefits and they didn't have anything in the fridge. And so they were going to McDonald's, but they were giving their just over a 1-year-old the apple slices from McDonald's. And quickly, there's a whole bunch of people that would just look at the McDonald's and have a lot of feelings about that. Mine was more of like, this is a choking risk. And there was a lot of education that I could provide, but I had to stop and be like, oh, this is what we can afford today. So how can we try and make this work with what we have? And you can turn the apple slices into matchstick apples, or you can make them so thin they're not a choking hazard. So you have to just not come from a place of judgment and kind of pause to wonder instead of assume. And again, it's just like being present. It's a lot easier to say that than to do that.
Yeah.
People think they do that, and then maybe they don't as much. It's easy to kind of get sucked into just like a lot of us get burnt out in our different systems where we work. And so sometimes it's hard to see that other side. So yeah, I mean, that's so important as well too.
Do you ever look back on how you practiced 10 years ago and think, oh my God, I wish I knew this, or oh, how I would have supported this caregiver different. And folks, to honor that statement, I highly encourage everybody to check out findhelp.org. I learned it from Julia Ochura and the crew up at Boston Children's Hospital when they had a presentation years ago about community-based resources, and how they had actually set up a garden there at Boston Children's. And that was so amazing to me that they were growing their own fruits and vegetables because, inner city kids, they were trying to support. But it is, each state has its own unique needs that are geographically, that are unique to the geography, and then the political, so geopolitical influences. But I mean, how in food deserts, access to whole foods is going to be more challenging. So we have to work with what we have access to, and then be able to, provide good care. Even it's not like there's just not one way to eat. There's not one way to live. We have to be able to see all of those different layers. And I also think too, that comes into feeding so if we go beyond the evaluation, we start to talk about treatment. Feeding therapy doesn't have to involve food, which is another hot take. You can do feeding therapy without real food in front of you. And a lot of kids need to start there. Their systems are not in a place where they feel safe around food, from, anaphylaxis that they've experienced, ongoing chronic, or like celiacs, right? So that, as well as just having a choking event, or every time you put it in your body, you're just so overwhelmed because of your sensory processing system. So you can start treatment without food. I'm giving you permission to do that and to try it. So that might, so that evaluation can be a glimpse into what the child's special interests are. Do they love books? Do they love technology? Do they love stuffed animals? Do they love drawing? And so all of those things, get an idea of that, because that can clue you in to where you could go, and not only what could you do with real food, but what could you do without real food as well too. So if it's stuffed animals, or like pretend play, do you have pretend food and the stuffed animals act out what they're doing with food, and which foods are their safe foods and which foods are their fear foods, and what strategies could they model and use to try the foods. I've had kids use Canva and make PowerPoint presentations about that's awesome.
And I had one kid in particular who his stuffed animals were everything to them. Not only did they have names, they had birthdays, they had backstories. I always joke they probably had social security numbers. they had a whole background. So we would make a profile for them in a presentation mode, and we would talk about what their favorite foods were, what their fear foods were, what they liked about those foods. So we started to use that descriptive language. or why they didn't like those foods, and how they felt safest trying the foods. So we're still going through all our strategies. It's just in this hypothetical situation, but that's where we felt safest. If we had put real food in front of us, we were at his house, he would have went like bolting down the hall away from it. And I would have had a complete fight or flight response. His, upstairs brain would have been offline. So this way allowed his upstairs brain to stay online and for his whole body to work together. We also, in the same breath about Canva, I have another kiddo who we're using real food, but we use the videos on Canva as models. So panda bears are fantastic. How they eat bamboo looks just like a veggie stick. They bring it right to the side of their mouth. We watch them do that. We watch, bears are our thing. So we watch then brown bears, we watch polar bears, we watch them tear the fish with our tearing teeth or crush the bamboo with our crushing teeth. And now with his mirror neurons, he gets to watch this. And now he is doing the same thing over here. And he uses a system. He has come so far. We used to just see food within probably a foot of him and he would gag and throw up. And now we're using a system called the side biter. And we also use the gumline feeder from Easy Peasy too. And we put different food types in there. So a little breaks off. So he can practice chewing or compressing, but then there's still that action that happens after. There is a taste of something, whether it's a little juice or a little pulp or a little crumb. Now we have something there. We also feel, we have that feedback of, is it crunchy? Is it squishy? So we get to now, again, bring in that sensory processing of what's inside of it without overloading the whole system. And that feels safest, but we use the videos to help with that.
You're reconnecting the central pattern generators for respiration, mastication, deglutition, because that's where the non-speech oral motor exercises, like we know if we practice it in isolation, it doesn't carry over to the act of timing, breathing, chewing, and swallowing. But by having the actual food present, you're connecting those CPGs in real time so that they have to do what they're supposed to be doing. Okay. I love using YouTube videos, but you have to be very careful. I try to do YouTube Kids. Because otherwise you can go to deep, dark, scary places. But alligator versus a mouse, because of an old conversation with Marcia Duncline when she was talking about like the size bites. But also for my home health kiddos, I like starting sometimes at the grocery store. Because of a conversation with Melissa. I have to connect you guys. Melissa from Mississippi. Her and I were at the Misha conference a few years ago and we were having breakfast together and we were talking about, she's like, for so many of these kids, the food just shows up in front of them. Like it just shows up. And did they have the independence or autonomy to select it? And she is spot on right. And so, it may not be great for an 18-month-old to go to the grocery store, but if we're 2 or 2 and change, and oh, by the way, we also need strategies for getting in and out of the car and getting into a grocery cart. You're carrying over self-regulation, you're carrying over self-help skills, and the framework of early intervention, it's daily routines. Caregivers often take their kids to the grocery store. Now, there are some children that we just can't and that we have to work up to there, but just exploring the foods and then putting it in a cart or weighing it.
Getting a frame of reference, right?
Yes. I also am very quick to practice what I preach, and I do take the kids to the grocery store with me. My own children have had exposures, and it's really neat when it's more than very neat. It is very joyfully overwhelming and makes me a little tearful when I'm at the grocery store with my kids and I run into another caregiver and their child that I work with at the same grocery store. And I it's just one of those luck would have it, divine intervention, but they're talking about a food or they're weighing a food or and I'm like, we just talked about this in therapy, and here they are doing it, and here I am doing it. And this is a small town. That's happened more times than not just since we moved. And it's very, I feel like what I'm doing matters in those moments.
And I would imagine them then seeing you practicing what you're preaching.
Yeah.
And even if they run into you at your not best moment, being a real person in the grocery store,
like, sit down, Theodore Alexander.
Seriously, like, don't eat the grape, like from it or something. Like, we're not eating, we haven't bought it yet. Stop touching it. That I think also is like, she's a real person. She's not just this robot telling
doing her
me,
job.
Yeah, like a step-by-step system from a textbook. Like she gets it. And
yes.
I mean, that's what's so important. And I think that's where you take that like developmental step back in your lens and you decide, where is it that we need to start? If a kid is not, again, I said it earlier, if a kid is not yet engaging with you, starting a process where you're doing food exposures and food challenges and having them engage with the food itself might not be the step that they're at, and may end up actually creating a fight or flight response to activate. And over time could eventually create a medical trauma. And that's something we always have to be considering as well too, is that I said this in the presentation at Feeding Matters, is we have to bring the right tools to the construction site. Like a saw is a fantastic tool, but if we need a power drill, the saw is not going to help us. It doesn't mean it's a bad tool. It just means that it's not the one for right now. And we might need something first before we use that tool. And I think that's really important to stop and consider. Have you seen Tiny Chef?
Tiny Chef? No.
Oh yeah. It's really funny. It's like almost looks like claymation, and it's silly and short, and they'll make food, but also from super simple. They have Bumble Nums, and they talk about food all the time in that. And a couple of my GLPs will script from that. And one of my kids kept scripting about onion rings, which was an episode, and samosas was another one, but we did the onion rings first. And he also was a low energy kid, and his mom calls him a cat, house cat, or a man of leisure, we call him. And we just sat next to each other, and I put the onion rings in between us, and we had our own devices. And it was just like what you're doing on like a Friday night watching Netflix, reaching out to this, again, like that oblique position off to the side is a little less intense than that direct
face-to-face
frontal position. Exactly. Sometimes it's too hard to look at a new food in the face. So he just would casually come over, and he'd like feel it, and then he'd pick it up and he'd put it on his lips. And I always laughed because I said to them, she knew what I was doing and why I was doing it. But I was like, if someone walked into your house right now, they'd be like, what is this feeding therapist doing? He's like hanging out on the couch eating onion rings. But it's exactly what he needed. He was not the kid that I could have been like, okay, we're coming over here and we're going to, kiss this and lick this, or we're going to, pull it apart and like look at all the pieces and decide what's in it and like dissect it. We needed to have a really low key environment, like a Friday night hang is what we were doing.
and that's, you recognize that in your tiny humans or not so tiny humans, because you've established trust, because you've gotten to know them. And okay, I have super simple, silly songs. There's another one, the foods that go together, broccoli and ice cream.
Yeah. Do you like broccoli?
And I do.
Yes, I do.
Yucky. But I have a little girl who would sing the song, and then we finally interpreted that her singing the song, she wanted to explore those foods.
Yep.
So we tried foods from that song, and broccoli and ice cream do not go together.
No.
But just having them there to experience it. I mean, that's so many of our kids learn about foods through music, through literature, through videos. And I, Yeti and my spaghetti, incorporating these into our practice. But to go back to what you talked about, like early literacy, the books about food and like cooking. And I had one mom, the little girl that I worked with, family, half of the family was Filipino. And so they went to the library and checked out books about Filipino food. And I thought that was beautiful because I mean, their family has two different cultures. And now, was it harder to find books on that? Absolutely. But what are your other thoughts on like your final thoughts on wrapping up trauma informed treatment or trauma sensitive treatment? Sorry, I misspoke.
I think it's always being creative and thinking outside the box. I had a kid last week who, like, I said it, I think he just developed a brand new plan of how we treat our older kids right now with what we just developed in this treatment session. And a lot of what before I kind of get to that, a lot of what I do is work through helping them. So I was ready to talk all about praxis and what that means and how a lot of our kids haven't even developed that for coming up with ideas and planning things out and executing it. I mean, that was a whole presentation at Feeding Matters with my OT friend. And so in that same breath is, besides praxis and coming up with ideas, is you have to also learn problem solving skills. And I've been talking about this so much lately, is that, after we can regulate ourselves and we can be engaged and now we're communicating about food, we have to learn how to problem solve. And that's where praxis comes in, is like getting an idea. So if you haven't learned how to come up with ideas, you're not going to, and all of a sudden you do have a frame of reference for a food, and it is your only schema of what that food is. So it's kind of like when we say picture a dog, and you're probably going to picture waffles, but I'm going to picture my dog Spud. Is you picture a chicken nugget and you have a certain chicken nugget. I picture a chicken nugget and it's different. And then if a different chicken nugget comes up, we're like, you and I know. Right. You and I know now, because we have praxis skills and problem solving skills, to be like, oh, right, it's a chicken nugget, but like, that's not a McDonald's one. That is a homemade one, or that is a gluten-free one. But when you don't have those skills to be able to then come up with ideas of what it is besides your schema or your one frame of reference, that is going to elicit a really intense response, because you're like, what's that? I don't know what that is. What do I do with that?
This ties directly into, we're speech therapists first. This is semantics. This is basic semantics, word, world knowledge. Do you know what this word means in the framework of the world? And so many of our kids are the overlap. They have a language delay or a language difference. And this is why we're supposed to do feeding therapy and language therapy together to address this together.
And not in a silo either, because you now need to be able to come up with ideas of, okay, it looks different. Let me figure it out. But what could I do with it? Is it a chicken tender and not a chicken nugget? So could I make it smaller like my chicken nugget? Could I add ketchup to it so that if it's a new brand that might taste different, the ketchup can mask it? And so again, when we come up with protocols, we might be missing this earlier developmental skill of helping them develop language about it, schema for it, and ideas about what they could do. And when you have ideas and you're okay with working through ideas, you delay gratification, because you're like, okay, I'm okay with this being different because I'm going to work through it. I'm going to come up with some ideas. They may solve my problem. They may not, but they probably will if we can come up with enough ideas. So working first there with my kids, and that might be through the play of like is this blueberry a boulder, or is it a wheel, or is it this? And eventually, talking about what it could be. This one's a little squishier, but it's still a blueberry, right? Or this one's a little darker, but it's still a blueberry, that it still is that, and it can change a little bit. Right there, that's going to change a lot of things. But that doesn't mean we're okay feeling those differences. And that, I think, is then the next thing is like working with the kids to develop the strategies they need to feel safe while they work through those ideas. Do you need something physically for your body? Do you need to bring your favorite stuffed animal with you? Do you need to sit with the weighted blanket? Do you need to do some deep breathing? Do you need some positive affirmations to say, or like some growth mindset affirmations specifically about food? Like my favorite is, I can try again and it might be different. I use that in my own life, not just eating therapy, right? That's like, I think that's our biggest fear, is like, we think it's going to be the same every time. So then we avoid it and we get in this circle of avoidance. So it's kind of figuring out, like, do you need to start what we call top down? So like some more cognitive thinking strategies where you learn the language and you learn the description words and you learn some information about the food or what you can do with it? Or do you need to kind of calm your fight or flight system first and make sure we're talking to that upstairs brain and our downstairs brain to say, it's okay, we'll be fine, we can stay online, we can work through this, we don't need to flip our cap. And being in that kind of part is a huge thing. And one of my kind of like things that I work through a lot is I use a stoplight for a lot of kids. So them starting to understand that they have not the color per se of the actual food, but a green food is a safe food. They're like, okay, I feel comfortable. A red food is a scary food. And then a yellow food is one that I'm interested in exploring. I'm curious about. But I talk a lot about like the yellow on a stoplight. There's a part of the yellow that's really close to the red and a part of the yellow that's really close to the green. And so there's some where you're like, I want to explore it, but that feels really kind of almost too scary, or I feel pretty good. And so then I kind of take it to those steps to eating, and I align the stoplight with what level they feel like they could reasonably start at. Instead of me determining it, I'm like, okay, so if you're yellow close to green, do you think we're more going to do a taste today, or are we going to like take a whole bite? And then they get to be in charge of where they're exploring it that day.
Sorry, Waffles is cobbling, and she does this. Folks, if you don't know what a cobbling is, it's where we like nibble hard with our teeth, and it's I love you. Like, yes, this is my safe person. So Wobbles is self-regulating. She's loving you so much. So the other part is I talk about our risk meter with them. So what's your risk meter today? And how risky does it feel to explore this food? How brave are you feeling to take a risk today? Because there's some days where the kids didn't sleep well, school was really hard, they rushed to therapy, and they're like, oh my God, I'm so spent. It's not the day to have me try this brand new food. Or it is a day where they're like, okay, I feel really solid. It's going to be risky, but I can be brave, and I'm ready to do this level. So we kind of work. You're letting them set the pace and lead, and and so much of feeding, they're told what to do, when to do it, how to do it. And that you're putting them in the driver's seat to carry on with your like feeding or your driving. Comparison
with the stoplight.
Yeah. Mm-hmm. Also, as soon as you were like, well, is it a green yellow or an orange red yellow? That to me, in my mind's eye, it's like, how hard does mommy push on the gas pedal?
Correct. Yes. Right. So that. Then, and I'm working on a workshop with a social worker that we're going to combine caregivers and kids into the same sessions. And we're going to flip-flop them for that exact reason of, yes, you need to hear what your child is thinking and how they perceive this so that you can then, and that's co-regulation, right? Of like, yes, I can't keep pushing because you're telling me this feels too risky. Okay. And I mean, what a life skill also. Like that is going to be fantastic for your whole life of like, okay, I can push myself. I can do something that's outside my comfort system with these supports and with, voicing my needs and self-advocating to people who I know will respect what I need and help me through this. And I can do something that scares me. I mean, that's a life skill. So like if they never eat a food with me, whatever, that I just taught them a life skill that will go with them for their whole lives. And that also, again, builds that relationship with the caregiver because I don't live with them. I'm there with them 1 hour a week.
But building that relationship, it can also help heal it.
Yes.
And so many come to us and they need that relationship healed.
Mm-hmm.
And so,
yeah, they've been just butting heads for so long. And it's been such a point of contention. And it's how do we start to find some joy or at least neutrality? And a really fun one that, I mean, this isn't a new concept of like personifying your anxiety, but we'll make food monsters and food heroes, and we'll make our food monster really big, and we'll make our food hero really small. And then when we do our food challenges, when you meet that challenge and you are brave and you overcome your fear, that food monster gets a little smaller, and we literally make him smaller, and the food hero grows. And then you'll love this is, then I said, and this is the kid, I was like, you just made a whole program. This is a brand. I'm going to attribute this to you. So we also are like, as he grows, he should get good stuff too, the hero. Like we should give him a hat and he should get some shoes and he should get, I don't know, backpack. Like we should like ice him out basically. Like we should bling him out and make him so cool because he's getting stronger and more confident and braver and just more equipped. So let's create that visual. And then in the other way I do it, and I'll actually, if you don't mind me going off camera for a second, is we have these mason jars that we keep. I gave them out as Christmas presents to everyone that was on our caseload. And inside, we have a little baggie of pom-poms. And so this gets to be our positive mealtime pom-pom jar. So we even brought that into our food monster, food hero, where when we get to have that moment where the food hero was really brave and grew, we get to like show ourselves that we did it. We add the pom-pom to our mason jar because now we get to bring back Maslow's. We also get to feel capable and confident, and that's going to build our esteem. And so we're going to work our way up that Maslow's like hierarchy right there too, is like, look how many pom-poms you got. It's not that we're doing, it is an extrinsic reward, right? But it's because we started with intrinsic. We wanted to do this, and extrinsic's important, right? We get paid for doing our work. We get ourselves little treats.
Yes, we do. But this is, there is a balance, right?
Right. And so some kids truly have not ever felt capable at the table trying new foods. And our brain wants to remember negative things and scary things because it's trying to keep us safe. But we need to show it. No, it wasn't so scary. Remember, we did this. And that same kid, he hated the food that he tried last week. He was like, hate it. I was doing the Grinch, double hate, loathe. But we talked to each other about, you can hate a food and still feel proud of yourself. And those things, those things can coexist. You don't have to like it. You know, I'm never doing that again. But again, maybe we throw a positive affirmation. We could try again and it might be different, but like, I'll respect it for now. But I get to say, but are you proud of yourself? And like, that was a concept he had never thought of. He looked at me like, you're making my brain like crisscross right now. We'll talk about that again next time, Miss Lauren. But I think the way to kind of conclude that is, with all of those examples, I think it's pretty easy to show that like your goals also don't have to revolve around how many foods you've added, how many bites you've taken. It can be around reducing stress at the table, increasing engagement during meal times or at the grocery store or during food prep. It can be just maintaining regulation when someone else is eating a food that's not a safe food, having curiosity cues. And then you could even just have the goals be parent goals as well, too. We should be always educating the parents, involving them. They're the experts on their child. We should be collaborating. That's one of the 6 core principles of trauma-informed care is so it could be that they're showing us that they understand their child more, that they understand their sensory preferences. They can pick foods that make sense based on what is going on, what their child's repertoire looks like. It could be that they're modeling strategies themselves, or they're able to provide co-regulation when they identify some stress cues. So it doesn't have to just be that they took this number of bites or they added this many new foods to their food repertoire. There's so many other goals that we can pull in. And again, I think that helps when you are in a system where you have to submit to insurance and get insurance to approve. Yeah, exactly. So, yeah.
I have also worked with caregivers to write goals for following up with specialists.
Yes.
Hi.
Yes, I have too.
See,
I just had one about completing a swallow study, an MBS, just to make sure that we did, because I was like, I need that information before we progress.
Yes. And that is, folks, it is inside our scope of practice to request referrals. So, and it's
all in how you word it. We can't tell the doctors, right? But we can say, this is what I saw. And my recommendation is that we probably could benefit from a referral to ENT, to GI, for a swallow study. Yeah. And most doctors are going to welcome that when you find really great ones, but also you do want to respect the hierarchy a little bit, right? But most of them are like, my doctor I've worked with professionally, and he's also our family practice doctor, he's like, you're the expert on this. So like, you tell me what you need, but I still honor, his role by saying, but it's you who's writing the order. So I don't write the order. So I'm going to word it as like, this is my recommendation. And would you consider X, Y, and Z, so that they can say, yeah, that makes sense. And every once in a while, I get a good doctor too, who's like, well, I don't know if that's where we need to go to first. Would you be comfortable with doing X, Y, Z? And if the results show this, then we could go to that. I'm like, sure, that sounds great as well too.
Yes. Mm-hmm. And that is interprofessional practice at its finest. Yes. That's also you have to establish trust with those caregivers, trust with those providers. And let's be honest, it also means that the caregiver and the other providers have to have a relationship established in trust.
Yes. And something that has come up lately is I take on graduate students, and the one we have right now got to listen to me make a few calls to some doctors' offices to collaborate this week. And she was so impressed, number one, that I got doctors on the phone every single time. I got 2 personal calls back from the doctor, not their nurse. And she was like, how did you do that? Well, first of all, I selected the option where it says like providers, press 5. It's like, it didn't say doctors. It said providers. So I'm pressing that one, like, because I'm a provider, I'm important in this.
Yes.
And so then being able to kind of code switch in the vocabulary you use to come out of your therapist language and use doctor language.
Yes.
And that is the difference between saying to a doctor, this child is not progressing with their solids and they're sick a lot. And even that, I think, would give a little red flag to the doctor. But like, I'm just worried that they're not developmentally ready for PO intake. And that actually came up with as a really specific example with one of my SLPs. And I said, I think that if you hit them more with, this child is vomiting frequently in their sleep and presenting with chronic upper respiratory infections, and I'm concerned that they are either presenting with aspiration and they're always wet, coughing, that they're aspirating either during the swallow or after the swallow, and that their immune system is just not ready for safe intake. I was like, it's the same thing, but when a doctor hears recurrent upper respiratory infection, recurrent vomiting, frequent fever, that was the other one, like frequent fevers, pretty persistent fevers, doctors go, that's what I can treat. If you say like,
you quantified
concerned about their oral development, they're like, that's your job.
Yes. Yes.
I had a cardiologist once with an infant who they were tachycardic, and they were going to get surgery eventually. And I called him, was like, hey, like feedings are tough. And they're tachycardic, and I'm just a little concerned about, everything cardiac wise. And he said to me, and I loved him for this. He was like, well, is that going to change their surgery date? And I was like, probably not. And he was like, okay, well then you need to do your job as an SLP. And it kind of hit me. And I was like, you're right. Like, yes, there's some medical things, but are they big enough to change the plan of care and to expose this infant to anesthesia at a younger age and a big medical procedure? No. So that is my job, is to figure out how do we do, it's not ideal. It wasn't an ideal feeding situation, but how do we make it as good as it can be for right now so that we can get there? And that's important to think about.
But I love that the doctor could say that. And then my next thought is, and that's where for some of our kids, a short course with the feeding tube to get them over the hump and the hurdle so that we still maintain joy and safety during our mealtime. But we need to grow a little before incoming surgery. I just have a little one. I've worked with so many little ones that have Down syndrome over the years that have baseline cardiac conditions, but they have to be so big. We have to weigh so much, or we're waiting to see, will that PDA close on its own? Will it, and
do we even need surgery?
Yes. But like but that gets back to what we talked about when we started, going through the different types of trauma and having that trust-based relationship. We have to feel safe in our own muchness to create a safe space for a quality eval, to create great interventions led by great goals and interprofessional. Okay.
Yep. And then I was going to say, and then to just work developmentally through there and not skip any of those steps and go back if you need to. Like, no one says that you can't take a couple steps back if you need to. Like, you can always go back if you need to strengthen skills again. Like, that's okay.
And for some of our medically complex kids, it's going to go like this.
Correct. It's not linear. So like, don't feel like you can't go back and strengthen that relationship if you feel like something has changed. Again, sometimes they have a medical procedure and how they're feeling about feeding changes. So they go to the doctors and it changes. So like if something feels different, constantly reassess. And just because you were at a certain step doesn't mean you can't take a couple steps backwards and just start there again. Like, you're going to be better off for doing that. And they're going to be better off, and your relationship's going to be better off for doing that.
Thank you so much for coming back on. And then if somebody wants to reach you, how do they reach you?
Yes. So my email is my first name, Lauren, Lauren. And then it's at the name of my private practice. So it's Well-Fed Feeding Therapy, WELLFED, feedingtherapy.com. You can also reach me on socials with the same handle, at Well-Fed Feeding Therapy. You can DM me, you can ask me questions. I mean, I love to connect with people. So those are probably two of the best ways.
Okay. And then if somebody has love money, where would you like them to send donations or to support?
I know. I think I'm sticking with Feeding Matters. I wish I had something different to expand that to, but truly I just think, and that may be that you contribute money. It can be that you contribute time. I mean, the people who are involved with Feeding Matters and volunteer roles are just amazing. They create such amazing space for parents as well as clinicians. So, every single committee that I volunteered on has a parent who has gone through PFD, is experiencing it then, and just gives such good insight. And we just, you get to, it's from that grassroots level of like making sure we just get information out there. So it may not even be that it's a donation. It may be that you go on their website and you share their information. The resources are fantastic. Connect another person with it. That's a great way to do that too. Or volunteer for one of their community pillars, or like hop on their lunch and learns that they have once a month. I mean, there's so many ways to participate and to spread the message and the awareness of PFD that we need to.
Yes. Folks, I'm going to put a plug in for your local food banks.
Yeah.
In addition to Feeding Matters, but I should
have done that too. Yeah.
Yeah. But like it has come up so much at work the last 3 weeks. Like, learn
where your local food banks are, find their information. We have ours. It actually was like right down the street from our old clinic, which was so nice, in Manchester, New Hampshire. So just figure out where those are so that you can advocate to families who may be in need.
Yeah.
Yep.
Honey, I so enjoy our time together. Are you coming to Indianapolis for ASHA the end of the year?
Oh, you know what? I haven't even thought about that yet. Doesn't even cross my mind.
I mean, I haven't, but I've already started mapping out the year. But okay, we'll come back to that one. But folks, if you are going, don't forget, MBASLA is in Atlanta in April this year. So National Black Association Speech, Language, and Hearing, please stop by and say hi at the Speech Therapy PD booth. And then don't forget, November in Indianapolis. So put us in your box and then come by and say hey there. But thank you for tuning in, all of the above. Clearly, we teach people to talk.
Remember to visit speechtherapypd.com to earn 0.1 ASHA CEUs for this episode and to see our library of over 1,400 courses for all things SLP.